Okay, good afternoon, everyone. Welcome to today's meeting. This is the Scrutiny Board for Adults' Health and Active Lifestyles. Just like to draw everyone's attention to the meeting. Thanks for coming this afternoon. I'm really pleased to be back as chair for this Scrutiny Board, and there's lots of important work to do today. We've got, for those guests, just so you know, we've got a few more sort of business items to do because it's the start of the municipal year. So firstly, I'm going to do introductions for elected members only first, and then we'll come back to everyone else once we've gone through the first few items. So I'll start with myself. I'm Andrew Scotes. I'm a councillor for Beeston Holbeck, and I'm the chair of this committee, and we'll go this way. Thank you.
Councillor Mahaley France Meir for Moortown.
Good afternoon. I haven't got a jingle, but I'm Councillor Kevin Ritchie, Bramley and Stanley Ward.
Good afternoon. I'm Councillor Taylor for Chapel Allerton Ward.
Hi there, Councillor Hannah Bithell, representing Kirkstall.
Hi, Councillor Conrad Hartbrook, representing Rothwell.
Councillor Winkage, you're representing Morley South.
Councillor Lynn Buckley, representing Alwoodley.
Thank you. And Angela, can you introduce yourself?
Good afternoon, everyone. Angela Brogden, Principal Scrutiny Advisor.
Thank you. Can you go through the first 4 items, please? Thank you.
Thank you, Chair. Under item 1, there are no appeals against the refusal of inspection of documents. Under item 2, there are no items for exclusion. In relation to item 3, there are no late items. And under item 4, please may I ask at this point if board members have any declarations of interest? And I shall take silence as none. Thank you very much. Under item 5, we have received apologies from Councillor Gibson and Councillor Rontry, and we have Councillor Bithell attending as substitute member for Councillor Rontry. Thank you, Chair.
Super. Thank you very much. Okay, I'm going to move on to the minutes. Are there any matters of accuracy from the minutes that anyone wants to raise? No. Angela, are there any matters arising that you want to bring to the board's attention?
Nothing specific, Chair. Obviously, the last board meeting was very much a dedicated meeting, having a holistic view of how partners are working collectively around tackling obesity and around weight management in general. The board did agree to keep this on the radar in terms of tracking progress and action. So we're discussing other areas of potential work for this forthcoming year. This is an area that you may want to continue factoring in. Thank you.
Thank you very much. Okay, so move on to unless any other matters arising from members. No. Okay, so I'm going to move on to item 7. So co-opted members, as you will know and will have read from the papers, we can co-opt members, and we've historically done that with certainly the time I've been chair, Dr. Beale. Dr. Beale's no longer going to be our co-opted member, so I'd like to put on record and have it make sure it's minuted that my appreciation for him and the time he's given. I've always thought he's asked insightful and clear and direct questions, and that's been very appreciated, and having that medical background has helped. So moving forwards, so previously we've had the chair of Health Watch Leeds. Currently they have co-chairs. And so the proposal that's been put before us is to have a shared appointment. So generally one of the 2 co-chairs will come to the meeting and speak on behalf of and be the co-opted member. Because this is the first meeting and it's about work items, I've invited them both to come in case they both have something to say or share in terms of the work schedule. But going forward, there'll be one of them at each meeting. They also co-chair in other committees, and so they are aware of the need to share information. I'd like to ask members if they've got any questions at this point about that proposal. No. Okay, so just before we vote on it, I don't know if we need a vote, but before we sort of move on, can I just ask Jane and Jonathan to introduce yourselves, just a little bit about your background, and that'd be great. Thank you.
Hi, so I'm Jane Mashenko. Nice to meet you all. Very hard shoes to follow, Dr. John Beale, of course, but we'll do our best. My background is I started off as a nurse, Then I worked in the NHS in all kinds of different places. Ended up in the community before becoming a Commissioner of Children and Maternity Services. And I retired a couple of years ago. I'm very pleased to be here representing Healthwatch.
Thanks. My name's Jonathan Phillips, and I've been with Healthwatch for about 5 years now, but like Jane, co-chair since January. My background is in social care. I did lots of different things in social care and in the voluntary sector, particularly around deafness. I worked in the Department of Health in the Social Services Inspectorate and as a regulator with what was CSCI, Commission for Social Care Inspection. And my final job before I retired, which was a bit longer ago than Jane, I was Director of Adult Social Services in Calderdale. So my background's very much on the cusp of health and social care. And I'm really looking forward to being part of this scrutiny. I think it's going to be very interesting and hopefully we can both be productive.
Super, thank you very much. So just 2 things on that. So firstly, I'd like the board's support for me to write a letter of thanks to Dr. John Beale that I'll sign, but on behalf of the whole board. And secondly, are we comfortable to accept the co-chair arrangement? Yes, I'm taking silence. You've seen nods around the table. So that's good. Thank you very much. Brilliant. So now welcome as co-members. Thank you. Okay, so moving on to item 8, which is the terms of reference. This is just to note, so the opportunity to ask questions, but it's just for knowledge of what the agenda, what our remit is. I think it's really important to recognise that, as you'll know, members, that we have were on the previous board, we have done joint work where that's appropriate, but that is to note. So I'm not seeing any questions. So again, I'm going to move on to the next item. Okay. Next item is local authority health scrutiny. Angela, could you just outline this paper, please? Thank you.
Thank you, Chair. So as members will be aware, it's this scrutiny board that's been assigned to fulfil the Council's statutory health scrutiny function. And so this report does present information and guidance to assist the board in undertaking that specific role. It highlights the impact that the Health and Care Act 2022 has in terms of introducing substantial changes to the organisation of health and care functions across England, as well as its impact on the role of health scrutiny, with particular references that are made to the publication of new national guidance, which was published back in January of this year. The report also makes particular reference to the duty of NHS commissioners and service providers to consult local authorities through the health scrutiny function, where any proposals under consideration for a substantial development of the health service or of substantial variation in the provision of a service in the local authority's area. And to assist in this process, a health service developments working group approach has previously been established, and this offers an environment that allows early engagement with the scrutiny board regarding proposed developments or changes to local health services. And so it's proposed that we have similar arrangements established again for this municipal year, with the draft terms of reference appended to the report for members' consideration and agreement. The report also mentions regarding joint health scrutiny. So under the existing regulations, there is a requirement for local authorities to appoint mandatory joint health committees where a relevant NHS body or provider consults more than one local authority about substantial reconfiguration proposals. So under these regulations, local authorities can also appoint what is regarded as a discretionary joint health scrutiny committee. So the board's attention is drawn to the existing West Yorkshire Joint Health Overview and Scrutiny Committee, which we often refer to as JOSC. This was established back in November 2015 as a discretionary joint committee. And the membership consists of 2 members from the relevant health scrutiny committees across West Yorkshire, with each constituent local authority nominating again to the two members, and Leeds representatives has generally been the chair and another member of this scrutiny board. So with regards to this report, members are therefore asked to consider the board's representation unjustly again for this year, Chair. I'll leave it as that.
Super, thank you very much. So I think there's two things. The first is the working group stuff, which I think is really important. And it just means that we can have working groups on issues. So either if we don't have enough time in our formal committee meeting schedule, we can add extra meetings in, or if it's something that is slightly more confidential, we can have a full and frank discussion out of the public eye, and then we'd bring back a summary paper to this meeting. And just the same with the JOSC is, whilst there is a body, it's not a statutory body, and so anything that was going to affect Leeds would still need to come back to our scrutiny board because it affects Leeds, and we are the statutory consultation body that the NHS has to consult with for changes in Leeds. So last year it was myself and Councillor Anderson, who were the nominations. Obviously, Councillor Anderson isn't here. I propose we keep the same unless Councillor Anderson objects when she's next available. Yeah, we're happy. Yeah, Councillor Anderson has good attendance at the meetings, which is it's always a good start. Great. Okay, so I'm going to take, unless there's comments, I'm going to take that as agreement to these proposals. Yeah, great. Super. Thank you. Great. So we are now through the main sort of business items, which at the start of municipal year we have to get through. So that is positive. So we're going to move on to sources of work, which is really important. And essentially what I'm asking is, where should we spend our time over the next 12 months? Because we didn't do this earlier, I'm going to go and ask everyone who's around the table to introduce themselves, who didn't introduce themselves earlier. And then we'll move on to a conversation. So I'm going to start with Councillor Bromley, because, yeah, you hadn't arrived earlier. Thank you.
Thank you. I don't know if that was just me. So, yeah, Councillor Bromley for Horsforth and Rawdon. Thank you.
Yeah, and then Councillor Arif, and carry on. Thank you.
Hi, good afternoon. It's Councillor Arif. I'm the Exec Member for Adult Social Care, Active Lifestyles and Culture. Thank you.
Hi everyone, I'm Councillor Fiona Venner. I'm the Executive Board Member for Equality, Health and Wellbeing. We have to remember our new portfolio titles, but yeah, Equality, Health and Wellbeing. So Councillor Arif and I will always be at this scrutiny committee. Thank you.
Hi everyone, Victoria Eaton, Director of Public Health for Leeds.
Hi, Tim Fielding, Deputy Director of Public Health for Leeds.
Hi, I'm Jane Wall. I'm Chief Officer for Active Leeds and Operations in City Development.
Afternoon, everyone. I'm Stephen Becker. I'm the Head of Active Leeds for Leeds City Council.
Good afternoon, everyone. Tim Riley. I'm the Accountable Officer for the Leeds Place within the West Yorkshire Integrated Care Board, ICB.
Good afternoon, everybody. I'm Sarah Monroe, Chief Exec Leeds and York Partnership, NHS Trust.
Good afternoon, I'm James Goodyear, Director of Strategy for Leeds Teaching Hospitals, here on behalf of Phil Wood, our Chief Executive this afternoon.
Hi, I'm Sam Prince. I'm Director of Operations and Deputy Chief Exec at Leeds Community Healthcare. I'm going to be joined in the middle of the conversation by Selina Douglas, who's our new Chief Executive.
Hello, I'm Shona McFarlane. I'm the Deputy Director for Adults and Health, and I haven't got a microphone. Thank you.
Good afternoon, everybody. I'm Caroline Barrier. I'm the Director for Adults and Health at Leeds City Council.
Great, thank you everyone. Welcome to the meeting. Okay, so I'm going to start by giving an opportunity to either of our executive members a chance to outline anything they think we should be looking at this year. So Councillor Venner, do you want to go?
Okay, thank you. So the part of the area of my work that's covered by the Scrutiny Board is health partnerships and public health. So health partnerships, I chair the Health and Wellbeing Board, and I have the responsibility for being the political lead for the the council's interface with the NHS. So I go to a number of NHS meetings, including a regional meeting called the West Yorkshire Partnership Board. That's all the leaders and chief execs and chairs of health and wellbeing boards. And I've been doing that for a while alongside children's social care, but this year I've acquired public health as well. So I've now got the whole of the health agenda in my portfolio. My suggestion, Victoria's got some other suggestions on the public health side, but the one suggestion I wanted to bring forward is really in recognition that we're going to get a change of government. Whoever wins, it's going to be a change of government, and could be a significant change of government. So I think we need to think about that and think about what that will mean, what the possible policy landscape will be going forward. And how I would suggest we frame that is that we've always had regular updates from Tim, from the NHS, as the NHS has reorganised, as we've gone into the structures of having the ICS and the ICB. I think it would be really helpful going forward to continue to have those updates and to have one soon after the election, which I guess would be the next meeting. I don't know if we'll know at that stage if there'll be any early health policy announcements, but I think we should have a meeting early in the life of a new parliament to look at what we think it means for us locally, for the NHS nationally, for the provision of health and care. So that'll be my suggestion, that we keep having the regular updates from Tim, and that we have a discussion early in the life of the Parliament about the policy framework we're now operating in. Thank you.
Thank you very much, Councillor Benn. And actually, one of the things I think on that topic is waiting list will be almost certainly on the agenda, whoever the new government is. And so that's something we should be looking at. Councillor Harris, do you want to come in?
Yeah, Chair, just to concur with my colleague Councillor Benny in terms of getting that meeting in early, I think there'll be some opportunities there for us to work on. From my perspective, I suppose two things. I'm happy for Caroline and Jane to also come in. In terms of active lifestyles, though we've made progress in terms of inactivity levels in the city, they are still very stubborn in areas of deprivation. And I think that perhaps there's more ought to be done on that agenda in terms of how we can change the landscape there. Coming on to adult social care in terms of challenges and perhaps some input from some scrutiny, we are struggling in terms of direct payments. That's one of the challenge, and all the work is happening with the Better Lives boards, and I think input from scrutiny in terms of direct payments and how we can do better there, as we do compare lower in terms of local authorities of a similar nature. So those are the two things that I'd like the board to consider. Thank you.
Thank you very much, Selma. So just so everyone knows my plan, I've got a list of all the people that we're going to hear from in terms of the speakers, and then I'll bring members in for questions or comments or items that they want to bring. So hopefully that's acceptable. So I'm going to start with Caroline to go. And I guess what I'm after is, what are your priorities for the year and the areas you think scrutiny should be focusing on? And then obviously we'll discuss that afterwards. Thank you.
Thank you very much. So one of the areas that, as with all directorates in the council, and of course our NHS colleagues as well, are our financial challenges and how we are working through savings and efficiencies programmes that we've identified in the last year to deliver savings in the current year, but also to some extent the plans that we are making currently in order to meet the financial challenges that we're going to face over the next 3 years. So in year, and also planning for future, and the work that we're doing in conjunction with our NHS partners, particularly around the space that is around integrated commissioning. Another area of focus for us is preparing for the Care Quality Commission, who are currently planning to visit every single local authority that has adult social care responsibilities. So a total of 153 local authorities over a 2-year cycle to come and do a visit around our compliance with our statutory duties in relation to the Care Act. So a huge amount of work has been happening over the last 18 months. We'd like to provide assurance to Scrutiny around that work and some of the pinch points, and Councillor Arif has already mentioned one of which is the position we still find ourselves in around direct payments. So explaining what our plans are, what projects are in place, and how we can assure that we are ready for CQC arriving. And that could be at any point. We will get notification, and once we get notification, it could be a period of 6 weeks minimum or up to 6 months for them to arrive. And then the third area that you might want to consider is that we are in the process of bidding for rehab and recovery short-term assessment beds, intermediate care, which is a tender being run by the ICB in Leeds, Leeds City Council, Adults and Health Directorate, partnering with Leeds Community Health to submit a joint bid for those beds. So those are just initial sort of 3 areas that I would suggest you look into.
Great, thank you very much for that, Caroline. Okay, I'm going to bring in Victoria Eaton next, please. Thank you.
Thank you, Chair. I've got 4 things just to briefly cover. Firstly, to add to Councillor Venner's point around the proposal around the policy agenda of the new government, just to kind of flag the public health elements of that. So obviously we're watching various things very closely. For example, what will happen to the smoking and vaping bill that was on the table pre-election being called, and progress around things like that. We noticed in the manifesto, as there are references to wider measures that we may use to tackle unhealthy environments, which pick up on some of the conversation we had on the last scrutiny board around healthy weight and how we can kind of push further on that environmental agenda. So things like advertising high sugar, high salt, fat food to children, it's very live in terms of manifesto content, as are social determinants of health. So, we are a marmot city. You'll be interested in how much kind of the new policy landscape kind of helps us take that word forward. So I think there's something about keeping abreast of that policy landscape from a public health point of view. The second thing, which is very brief, partly because it's already on the forward plan for next time, is the annual Director of Public Health annual report, which obviously people may be aware this is a statutory requirement to produce an annual report. So it does feel like a really important source of data. This year, the focus will be on ageing well. So there are things for all partners around the table to engage in that debate. So I'd certainly, it's already on the agenda, but I would concur that is a really critical kind of source of work. And then the last 2 things are similarly to the DPH annual report. We now produce a regular Health Protection Board report, which particularly focuses on our role around protecting the health of the public from harm. So there's a whole load of stuff in there which is regularly pulled together, and it feels a really useful source of discussion and debate around the priorities of that board and what we're doing to progress our work, which does include proactive planning for future outbreaks and pandemic planning as well, given the fact that the COVID inquiry clearly is very long running, and we are doing the local work now around that. So that's the Health Protection Board report. And then finally, in terms of echoing our priorities, both within public health but as a city, there is the whole agenda around health inequality. And one of the things that the board may be interested to look at is the progress that we've made around Leeds as a marmot city, now that we're halfway through our partnership with the Institute of Health Equity. So there is a lot of feedback we can bring to the board and discussion around the kind of next phase of that work. But it does feel important to say that the Marmot City work is one strand of wider system work around health inequalities. So it would make sense for partner colleagues from NHS, third sector and others to also talk about their health inequalities kind of elements of their core strategies as well. So it's a rounded conversation about how as a city we are focused on that kind of shared mission around reducing health inequalities, which will certainly come out in the performance report as the next item. So they were the items for me. Thanks, Councillor Scopes.
Thank you very much, Victoria. Okay, I'm going to bring in Jane next, please. Thank you.
Thank you, Chair. I suppose a little bit of a crossover with Caroline's introduction around how we're aligning Active Leeds to be more sustainable long term, ensuring that we get our investment income generation strategies right and make sure that we have a stable and quality offer moving forward. So we will be bringing forward our programme of investment to Executive Board later in the year, looking at how we maintain our facilities, but also create new across the city to make sure that we're getting investment, maximising grant funding streams through working with the Football Foundation and Sport England, and ensuring that we're aligned to their local football facilities plan, which has a significant amount of external grant funding associated with it, as well as ongoing conversations with Sport England to make sure that we're focusing on the health programmes that we work with Sport England on, to make sure that some of the work that we deliver in neighbourhoods continues and is proactive and is actually delivering the health and wellbeing benefits that cut across everybody on this scrutiny board. I suppose the other areas, just linking into some of the mayoral pledges as well, you know, there were a lot of culture references in there, but there were also some sporting references around pitch provision and ensuring we've got a good quality pitch stock and all-weather provision. We do have some challenges across the city. We're about 27 all-weather pitches short of being able to accommodate every person's training needs in the city at the moment. So it's making sure that we're linking into with WICA and others, so that they're some of the for areas of focus for us at the minute. So we will be coming back here, I'm sure, to have conversations about some of those in the future.
Great, thank you very much for that, Jane. Okay, I'm going to bring in Tim next, please.
Yeah, thank you, Councillor Scopes. It certainly pick up the policy point. I think that will be important. And it's going to be interesting how quickly and how clearly that comes out and where the focus is. I'd certainly expect waiting lists to be on there. I'd also expect general practice access. There's been a lot of conversation about general practice and primary care network type policy. So those are probably two areas we'd want to bear in mind. Also noted Caroline's comments around the rehab and the Link to Home First programme, which is sort of a procurement and organisation of rehabilitation and beds and services that comes out of that programme. So I think that is certainly big on our list as well from an ICB point of view. A couple of other things probably to mention, which may well cross over onto other colleagues' lists in a moment. I think there's an awful lot happening in the mental health space around the community mental health transformation. And also towards the end of this year, the Leeds Mental Wellbeing Service is up for review. So that gives us good opportunities as a city to think about exactly how we want to take that forward in light of the work that's being done across the community mental health transformation. So it's probably worth having some conversation at some point around mental health. I'd absolutely echo Victoria's comments around health inequality. And I think there are a number of things we could look at within that, particularly the Healthy Leeds plan, which is very much focused, whilst it's focused on specific actions and population groups, has a real inequality emphasis. And later in the year, I think it would be really worth looking at that, and also the core 20+5, which is the national approach to addressing health inequality. Again, there's work going on right across the city on some of those aspects. So I think if we were to do a conversation around health inequality, that would be a useful and helpful thing for all of us. There's a whole lot more I could list under that heading. one other area perhaps, which I never quite know, is neurodiversity waiting lists. I know probably colleagues, councillors will get members of the public talking to them about this a lot. I think the overlap and the crossover and the connection between children's and adults in the council, I'm never quite entirely sure where the best place to do that is. But it is important to say it's not just neurodiversity, autism, ADHD, and so on. It's not just children. It is actually affecting adults' services as well. So it may be worthwhile to look at some, if it's possible, some sort of joint conversation about that, because I think it's a key issue, and one we as leaders of the health service in Leeds with other colleagues are acutely aware of, and there are some real challenges around that area. And then finally, going back to Caroline's opening points, financial planning. We had a first sort of, I think, really serious attempt this year to do some alignment between local authority and NHS. The NHS working in a much more coherent way than perhaps we've done before. We want to build on that, doing some development work around sort of medium-term financial plan and so on at the moment. So again, I think it would be good if we could build on what we did last year and see how we could strengthen that in the year ahead. So colleagues are aware of some of the challenges and opportunities. That's okay.
Great, thank you very much, Tim. Okay, I'm going to bring in Sarah next, please.
Yeah, just to confirm, I think it's already on the draft work plan, the review of crisis provision and the ongoing implementation of community mental health transformation. It'd be important to for the board to be fully cited on that. The other area of particular focus for us this year is in working age adult out of area placements. So we reached a peak at the end of the last financial year of 40 adults who were in beds outside of Leeds because we couldn't meet their needs within the provision within the city. We've got a significant programme of work underway in collaboration with Leeds ICB colleagues to start to bring that down. We've started to see that number coming down, but it is going to take a concerted effort over the next 12 to 18 months. And I think that's something that the board might be interested in hearing about, but also to be assured around the work that we do to support service users and their families when somebody's placed out of area, recognising it's far from ideal and causes significant challenges to maintain that local contact. There is work we've got planned specifically around complex rehabilitation for adults with serious mental illness, with some significant capital investment to improve the provision within Leeds, which we're just drawing up. So again, that might be something that the board wants to hear about. And just the final point I'll make, which is the board has previously had updates, and it goes to the Health and Wellbeing Board, is the work that we do through a citywide partnership called Synergy Leeds, where we're working in a very the truest sense of multi-agency partnership, grassroots work to intervene early to address what we see at the wrong end of the pathway, which is overrepresentation of Black men in particular detained under the Mental Health Act. It is an innovative piece of work, and I think that's something that we should be able to share here.
Thank you very much. Okay, I'm going to bring in James next, please.
Thank you, Chair. So as other colleagues have already mentioned, I think planned care waiting lists and the elective backlog will be an area of interest for the board. Alongside that, and I could see in the work plan that the board has previously looked at our system resilience and winter planning, and I think urgent care will continue to be an area of interest. Workforce availability and resilience, I think, is key across health and care, in an area that we're working together as health and care partners on, and we're encouraged by the publication of the NHS workforce plan, but clearly that only deals with part of the picture, and also remains to be seen how that will be affected by the change in government. So that's a key topic area. And then lastly, the investment in healthcare infrastructure, and particularly thinking about the progress that we're making on plans for the new hospital at the Leeds General Infirmary, the new home for Leeds Children's Hospital, I think would be probably an area of interest for the board. Thank you.
Yes, thank you very much for that, James. Okay, I'm going to bring in Selena next. Thank you.
Hello, everyone. I'm Selina Douglas. I'm the new Chief Exec of LCH, and just getting to grips with the technology. I just wanted to say hello, but I'm going to actually ask Sam Prince to do our presentation for LCH. Thank you.
Thank you. So 3 things from us, and there's a degree of overlap with what's already been said, but the first one is around our cost improvement programmes and perhaps a look at what we're all doing to make sure that inadvertently we're not disadvantaging particular communities. The second one is around, again, linked to the community beds tender that Caroline talked about. How do we ensure that we maintain system flow through that tricky time whilst we're looking at what the new service provision will be, whilst keeping the existing show on the road? And perhaps linked to system flow, looking a bit more at admission avoidance rather than faster discharge, so that we can look at keeping people out of hospital in the first place, rather than ensuring that they have a quick movement out of hospital. And the third one, again, has been talked about, our approach to neurodisability and the system approach to that, rather than it being a health service approach, what part the whole system has to play.
Super, thank you very much, Sam. So now we're going to open up to members in terms of comments or questions or work items you think we should be asking about, obviously including our co-opted members. And then what we'll have to do is take it all away and try and come up with a work schedule. So I'm going to start with Councillor Hartbrook.
Thank you. It was really good to hear such a diverse range of topics aired there, and I think it touches on something which sort of, I know as a committee we've looked at before, and in Leeds we get an awful lot of things right, but the touch points between the different services, and I think the phrase you used about this, the whole service kind of approach, because as individuals we'll all feel it. That you go to a GP, it's difficult to get an appointment, therefore you go to something which arguably is a more expensive, more urgent service instead, or hospitals are full because the care beds aren't available. So I'm particularly interested that as we look at a whole system approach across Leeds, we go, well, actually, where are the pressure points, and where do we need more of something? And I won't say less of something, because I think we need more of something right the way across the board. But certainly there seems to be some areas, and general practice seems to be one. And I particularly go back to last year we had a GP in that gave a very compelling narrative of how general practice had changed over recent years, and that's clearly something that needs addressing. And it feels as though general practice is the kind of the nexus of lots of what feels wrong with the NHS, but I don't think they're causing it. I think they're kind of victims of it as much as anything else. So I think as a board and as a city, anything we can do to look at the whole system approach, so that we either change within our city or we lobby at government level to work on to get the best approach, really is valuable.
Yeah, thanks for that. And I think the phrase I'd use is system flow. And what I like is what you're talking about touch points, whether that's GP or the intermediate beds that Caroline was talking about, or a home first approach, is about how do you get the right service to the right person. Do you want to just come back on that?
Yeah, absolutely. One thing I meant to mention is I was listening to the radio a couple of weeks ago, and there was somebody on from the Nuffield Trust that were being quizzed about the various political parties' policies. And one of the phrases that they used was, you see pockets of best practice across the NHS, not large pockets in many cases. And the phrase that stuck with me was making best practice become standard practice. So that's basically where you take what works really, really well in one city or one area and go, actually, that is the gold standard way of doing it. Let's do that right the way across the board. So I think that's a really interesting area.
Thank you very much. I'm going to bring in Councillor Ritchie next.
Thank you, Chair. Thank you, everybody. I'd just like to augment a point that Councillor Arif made in terms of active Leeds take up, and you specifically mentioned the low take up in deprived areas. Could I ask that we also include disabled people as well and look at the take up there, the opportunities, perhaps flexing the service in terms of getting more participation? If I think this data would support that there's a lack of participation from that group as well. So thank you.
Thank you. I'm going to bring in Jane next, please.
Thank you. I don't know how much capacity scrutiny has, but it sounds like there's a lot of good things to explore. The thing that really grabbed me personally was how many people talked about inequalities and the need to scrutinise that. Completely agree. That needs to be beyond just the Marmot work, but right across all of the services. So it's great to hear so many of the key providers reflecting that. And also to bring together what Caroline mentioned in terms of financial challenges and difficult decisions that have to be made, and making sure that that then, as Sam said, doesn't disproportionately affect those who are more vulnerable. So it's really good to hear that. The other thing I'll mention while I've got the mic is it's really good to hear so many things referenced here that are really critical that we're hearing at Health Watch, such as mental health, such as GP access. So yeah, and the neurodiversity waiting list that I've just come from an event that we were supporting at the market where parents and adults were telling us about the challenges of waiting a long time. So it's great to hear all of these.
Thank you very much. Okay, I'm going to bring in Jonathan next.
Thank you, Chair. Yeah, in addition to what Jane was saying, I was interested in what you were saying about direct payments, and that Leeds is struggling a bit with that. And I think it would be useful, if we're going to look at that, that we look at it within the broader context of personalisation, and whether the fact that we're behind in terms of direct payments is to do with a wider culture that we're not quite getting right. So I think we should broaden that discussion out. I also think we need to, and this touches on the points that were made about we may have a new government, what's going to happen around social care reform, and that we need to be poised to enter that debate and develop our view about what might actually work to improve the situation at the moment. And a final point I wanted to make was that a lot of the solutions that are being proposed at the moment seem to rely quite a lot on enhancing digital skills and digital resources, and they work for a lot of people, but they can also run the risk of further excluding people that haven't got access to that. So as we develop that during the year, and it links particularly into looking at GPs, for example, we need to make sure that we take a really close equality view around that, that in making progress there, we're not excluding more people over there. Thank you, Chair.
Thank you very much, Jonathan. Okay, I'm going to bring in Councillor Bithell next.
Thanks, Chair. So just to reiterate, I guess the importance of what Angela mentioned at the beginning around keeping obesity and weight management on for me, and also having listened to what everyone's been saying, the clear links between that work and the mental health, the trauma, the poverty, deprivation as causes for it to continue to relapse over the lifespan, would make it quite a nice thread throughout, perhaps. And I also wondered whether, also linking to the trauma-informed approach that the ICB are taking around weight management and obesity at the moment, whether there's something that could be looked at around trauma-informed approaches to healthcare more widely in the things that have been discussed today, and whether, again, that might be something we want to look at more widely, or rather you do, because I'm only substituting.
Thanks very much, Councillor Bithell. Okay, I'll bring in Councillor Taylor next.
Chairs, I agree with everything each and everyone says, because the city do need it, and I agree with Angela suggestion to keep many of things going. But my part that I really want to focus on this year is health and equality around housing, mental health, and the elderly, because we haven't got an NHS. We have a name, but the NHS isn't there as it should be. So we need to focus more on the vulnerable around health and equality.
Thank you. thanks for that. Those have been really helpful comments from everyone. And there's a lot to take in terms of the scale of challenge and our limited time. I think that there's one other thing I'd like to raise sort of separately, which is Councillor Farley wrote to me about sexual health services. They're currently being in the middle of a transformation at the moment, and I think there's a question about how that affects access and who gets to use how you get access to those services. So I think that is something that we should look at. I guess more broadly, I feel like the health inequalities theme is something that's come out the most. And I think we've for a long time as a city said we want to improve outcomes for those at the bottom the quickest. So I think there's something around doing an audit of that and looking across the themes, whether that's the wider determinants that Councillor Taylor and others have talked about in terms of housing and other issues which affect health quite profoundly. And I also think there's something really powerful about what Sam said around the cumulative impact. And so whether that's if services are no longer as local in the community, everyone's paying for transport, that affects some people more than other people. So I think there's a really strong theme there. And I feel like we're going to have to find a way of bringing that all together. So I think that's really good. And I think there's also a lot of sort of the mental health situation and the provision there. And I definitely think what Tim said earlier around a transformation coming, I think we want to be in on that before the decisions are made to make sure we can comment and share our views. I think that's really powerful. Right back at the start, Caroline talked about the Quality Care Commission coming and assessing us. And so I think getting that in as soon as possible. What I think I'm going to probably suggest is having a working group on that so we can get it in before we would find time on the agenda so we can get some assurances about where we think we are before they arrive. I think that would be very good. Yeah, and I also think that I think James mentioned the Children's Hospital, and I think we need to look at after the 4th of July, making sure that's still on the agenda for Leeds. Obviously, that's what we're most bothered about, how the impact for people here in Leeds. So I think those are all massively important. But I haven't re-said everything everyone said. It's not because it's not important. It's because I guess there's only limited time. But I think that's really powerful. So I think what I'm going to suggest is, in terms of the agenda, I'll go away and work with Angela in terms of working up an agenda and sort of put that as a draft for the next meeting, and then obviously we can knock it about. Councillor Taylor, did you want to come in?
Just thinking, Chair, Councillor Bettle spoke about obesity. I think we need to work closely with licensing because in the deprived area, there's a lot of junk food shops opening, and that's something we need to look at. So I just think maybe we need to bring licensing and just to planning to see where the shops and because the deprived area is too many junk food shops around.
Yeah, thanks for that, Councillor Taylor. I think the last meeting we had, we talked a lot about the sort of healthy lifestyles, and I think there's a whole piece here around which, like we did last municipal year, from everything from sports facilities availability. So, for example, a couple of weeks ago, I went to a plans panel which passed a new sports development in Holbeck, which the area part of the area I represent, and that's going to be really positive because it'll be more football pitches that children and adults can play with. Not play with. You play at a sports pitch, and so that's really positive because having facilities locally means you're more likely to use them, particularly in some of our communities that have low car ownership. It has to be on the doorstep. But I totally agree with you. It needs to be a holistic look at that. So Victoria wants to come in, so I'll bring you in on that, please.
Thank you, Chair. Yeah, thanks, Councillor Taylor. Just to assure the board that from the extensive conversation we had at the last meeting around healthy weight across children and adults, that the work on bringing together a healthy weight plan for the city, which is system wide and all age, is continuing. So very happy to bring that back for a progress report at any point. Thank you.
Yeah, great. And I might ask you to work with Angela in terms of, again, working on a wider themed meeting, because I think, again, if we talk about one item here without capturing the wider determinants, again, it's really important to look at that. So that's really positive. Good. Yeah. So do either the exec members want to say anything at the end of this session as well? I'm not seeing a nod, so I'll move on. Good. So I'd just like to thank everyone really a lot for coming today. I think getting the agenda right is really important, and getting the right topics is essential. And I feel like as a partnership, there's a lot of crossover, and this idea, recognizing that the decisions each sort of organization makes affects the other organizations, and that's really important. And you've all talked about system flow as well, which I think links together. So thanks for coming. I really appreciate that. Okay, so we're going to move on to item 11, which is the progress report. I think our NHS colleagues, you're allowed to go now. Obviously it's a public meeting, so you're very welcome to stay if you want to sit in and listen. But yeah, you're not obliged to. I'm going to pass on to, is it Victoria who's going to introduce this, or Councillor Venner? Thank you.
I'll introduce the public health element of the performance report, and then obviously Victoria will be able to answer any detailed questions anyone's got. So this part of the performance report summarises how well we're doing to improve the city's health, and it shows progress across a range of health outcome measures and includes an overview of the performance of key public health services. So we can see, and this is really, really key in terms of the discussion we had earlier about health inequalities, that we know that it literally affects how long people live for. And so we still have differences in life expectancy between the most affluent and the least affluent parts of the city. However, overall, there has been a small increase in life expectancy, and that'll be closely monitored to see if that's an ongoing upward trend. There has also been a reduction in rates of death from people who are under 75 from preventable causes, and positively, it is declining most rapidly in the most deprived parts of the city. We've also got rates of obesity in children that have shown a decrease, particularly children in year 6. Public health continued to perform very well in specific areas. I think the one that jumped out for me was the drug and alcohol treatment services, that we benchmark incredibly well in those areas in terms of people completing treatment. And as we know, Forward Leeds has got an outstanding rating. It's one of the biggest drug and alcohol treatment services in the country. And the investment that we've made in Forward Leeds, I think, has really paid off in terms of those statistics show how well Leeds is performing in that area. When we talk about health inequalities, what's really apparent from all sorts of data is that poverty and deprivation are what drive health inequalities, and that impacts on a range of areas such as alcohol, smoking, and we've already touched on physical inactivity in adults being the highest in the most deprived areas. So that's just a summary of a few key points, and then I don't know if you want to add anything, Victoria.
Thank you. I'll just add a very brief comment on just a reminder for any new colleagues about how we normally do this performance report. So we basically highlights the commentary on the data that is new in this report. So the headlines that Councillor Venn has just pulled pulled some of the kind of main improvements and challenges from on page 117 is commentary on the new data in the report, and we pick out the things that are showing to be particular improvements for the city and particular continued challenges for the city. So I hope that's helpful just to kind of draw those to help you to kind of navigate the report, because we're very mindful there is a lot in there. What we don't do is comment on data that's not new in this report, but we keep it in for completeness. So it's all there every time, but we just highlight the particular content that is new data from last time, and we bring this every 6 months. So I hope that helps navigate the commentary and the content. But happy to take any questions. Thank you.
Thank you very much, Victoria. I know I asked you this in the chair's brief. I think it's an important question. So on page 128, infant mortality rate per 1,000 births, it's the average is lower than the rate for the least deprived and the most deprived. I don't like the term deprived, but it's a statistical concept. And I just wanted some commentary on that. And obviously the rate for those in the least deprived has gone up. So, and the overall average has gone up. So just some comments around that, please. Thank you.
Yeah, thank you, Chair. So just as a reminder, because this data hasn't got an asterisk by it, it's not new data for this report. It's included from last time because it's not been updated in the last 6 months. But it's still important. Happy to pick it up. I mean, basically, there's two things. The numbers for deaths under 12 months old, which is what this is measuring, are thankfully incredibly low every year. So if we see any changes, we have to be really mindful of small numbers, and what seems like a big jump may just be a kind of a normal variation in very small numbers. So there's a huge thing about just being really careful with the numbers being very small. Having said that, we are really interested in this line around the most affluent decile of the population, showing to increase even with very tiny numbers, because this isn't what we'd normally expect for deaths of children under 1, because it normally correlates with deprivation. So the more deprived, the more deaths we would normally see. So we are watching this carefully. We aren't kind of 100% confident around what's happening here because it is such an unusual thing, and the small numbers we're very mindful of. What we are having conversations with colleagues around and continuing to watch carefully is often with in our most affluent group, the average maternal age is higher. And that often brings complications, which may sadly lead to deaths of children under 1. So whether it's a sort of consequence of affluence that plays out in that way, that's almost one of the most likely contributing factors. There has been some changes in the recording of deaths, which may have also changed the pattern. So we're also keeping an eye on that. It was the recording was changed to include all live births, even if they were under 24 weeks old, whereas previously that wasn't the case. So again, whether that's changed anything again in those most affluent mothers, but it's still not clear at the moment. So we are just keeping an eye on that most affluent group. The other brief thing to say at the end is that because we look at the most deprived 10%, which is 1 in 4 adults for us, we know that's big for Leeds, and actually our least deprived, most affluent group is really small. It's about 55,000 people. So even though you've got small numbers in every bit of that, because we're comparing those two, you're likely to get more variation in the most affluent group. So lots of things to look at there. We are keeping a really close eye on it, but hopefully that's helpful for now. Thank you.
Yeah, thank you very much. Opening it up for members who want to ask questions. Okay, I'm going to start with Jonathan.
Thank you, Chair. In the commentary on the indicators, you mainly focus on deprivation, And I'm wondering whether you also analyse around other issues, particularly I'm thinking of ethnicity, which in terms of maternity might not necessarily totally correlate with deprivation. So be interested to know about that.
Thank you, Jonathan. No, it's a really good point. For this particular report, we've taken an approach over many years to particularly pull out deprivation and compare most deprived with least deprived, for the reason that it echoes that central ambition of the health and wellbeing strategy to close that gap. So that's the sort of rationale for being absolutely relentless on the inequalities from a deprivation point of view. So through this performance report, that's the way we cut it. And in this report, we don't normally kind of look at other protected characteristics or other factors. Now, within each programme area, the people leading the programme absolutely do. So if we were to bring something on any of these issues, we would want to bring that out, but it's just not routinely collected in this report. Tim, I don't know if you want to add anything.
Yeah, thanks. And just to add to that, absolutely, as Victoria says, and I think one of the things also to note is that one of the things we've acknowledged recently is that the diversity of the populations actually increased quite substantially, and so when we see all those ONS reports, actually the proportion of people from ethnically diverse communities has actually increased quite markedly in Leeds. And as part of the Marmot work that we did, one of the recommendations that's come out of that was presented by IHE and that we've been working jointly with them to the last Health and Wellbeing Board in July, earlier, it was about having a much more of a focus on ethnic diversity and the inequalities related to it in strategies and things going forward. So we've been doing quite a lot of work with our intelligence colleagues, but also other colleagues across the system to try and actually understand that and look into that a bit further. There are real issues in trying to include it into things like this reporting because of the quality of the data, that there is a quality of the data recording. So we're having a number of strands of work at the moment around that, some of that to understand actually what the level and quality of recording is around some of it to understand what the best means of doing that are, and some of it to understand where the real issues are in terms of the data. But we are looking at that more on a sort of system-wide basis, and I think through the Marmot work that will come out more strongly, and we'll be able to report that back. So yeah, it's something we're very, very much looking at.
Thank you. Okay, I'm going to bring in Councillor Ritchie next.
Thank you, Chair. I'm slightly confused. When I look at the on page 123, the improvements and the challenges summary, but then read on to the commentary, there seems to be sort of a slight contradiction. So, for example, an improvement is a decrease in rates of obesity in primary school children at year 6. But then when you read the commentary, it says that it's not a statistically significant change. That's one area, but it is down. And then similarly on a challenge around circulatory disease, and it says the gap continues to increase between the most and least deprived. But in the commentary, again, it seems to say there are no significant changes in the most and least deprived areas. So hopefully you can see why I'm slightly confused.
Thanks, Councillor. If I can come in on that. Yeah, I think they're absolutely fair comments. I mean, we try to be extremely rigorous through this in terms of using that statistical significance to make sure that we don't draw inaccurate conclusions, and that we're really rigorous in terms of being able to be clear where things have changed. And so we do include that in, and you're absolutely right to draw attention to that. What we're also trying to do, though, through the narrative is to try and cut through some of that, and where we think there are some notable potential trends that are noteworthy and worth drawing out, and we have tried to draw some attention to some of those. So really keen to keep those caveats in about it, but they're just trying to draw attention where we look across the spread of them. So I think with, for example, the circulatory disease, you're able to see through the charts that range between, so looking at pages 135 to 136, we've got a downward trend in quite a lot of those measures of mortality, which is actually really positive. And for most of those, we see the trend going down for both most deprived and least deprived. So it's broadly encouraging. What we were just trying to draw attention to is there does seem to be a bit of an uptick there in the circulatory where that gap is widening, and because of the change in the least deprived. So there's a risk in that case of the overall city level masking the fact of what's happening in the least deprived. So it is something, wherever we see something like that, as we've tried to say, it's generally keeping an eye on that to see whether it's the beginning of a longer term trend or not. And that's what we're really trying to draw out in the commentary. The one with the childhood obesity, I would absolutely agree. It is a very, very cautious positive because if you see it is a downward trend, but actually overall the levels for the last 2 years are still higher, considerably higher than they were in previous years. So we're still at a high level. So it is a very cautious positive, but it is encouraging that given the huge increase we saw over the COVID period, at least that is starting to show a sign of going in the right direction.
Yeah, can I just ask on that question, what level of statistical significance do you use? Like 95%?
Yeah, it'd be 95%, yeah.
So in summary then, it's the commentary that's more useful than the sort of key achievements, and go by the commentary.
It's the commentary that's the most statistically accurate. Yes, absolutely. But we also try to get the balance in this of being able to try and where if everybody doesn't want to read through all of the detail of that commentary, of being able to try and draw out some of the higher level themes for people in the commentary as well, that just gives some a flavour of some of the direction, while not hopefully hiding away from those challenges and where we've got those very significant ongoing quite deep-rooted inequalities that exist too.
Yeah, just to briefly add to what Tim said, I do really appreciate the comment, Councillor Ritchie, and this is something we wrestle with all the time, because often when we look at the data on a 6-month basis, even though we're seeing the lines go up and down, the technical position is there is no statistical significant change. Now, I think it's very difficult to always bring a report that says there is no technically statistical significant change, because actually that's, people want us to start to try to interpret some of it. Otherwise, it's just an incredibly tedious report which doesn't tell anybody anything if we're all saying there is no technical statistical change. So you're absolutely right, and this is something we do wrestle with. So I think that in terms of translating the graphs and the commentary into the headlines, we have to have a little bit of sort of descriptive license, but we do that with great caution. So but you're absolutely right to raise it. Thank you.
Great, thank you for that. So my next question is, and where I'm coming from, this is there are it's back to COVID, I'm afraid, and COVID vaccine deniers, and certainly in my local area, I've got a very strong vaccine denier public posts, and every time there's a sudden death, it's because of the vaccine and so on and so forth. But looking at this data, so we're getting into now 20 to 22, aren't we? Which I think we started having the vaccine, didn't we, there? And the numbers of mortality in circulatory disease is coming down. Is that something that we're starting to be able to use to counter those myths that are out there around? And I noticed one of the political parties is putting in their manifesto about again trying to tap into this cynicism and conspiracy theories around excess deaths. But is this sort of data helping to demonstrate that the vaccine is safe, as we all believe? And I'm about to have my booster next week, so I'm certainly believe the evidence and the science.
Thanks, Councillor Richard. That's a really great but quite a tough question. What we did see over the last couple of these reports was some data that was just really hard to interpret, because things like excess winter deaths, because we'd seen so many deaths in COVID, that a lot of the data, a lot of the patterns that you would normally see were completely out of the window, because we'd have this major disruption of the virus that sadly took so many lives. So some of this data has taken quite a lot of time to settle down, almost to kind of the new normal pattern. But to answer your question, I would see that it is helpful evidence that actually we didn't see this spike in deaths from, you know, other causes at the time that the vaccine came out. If you want to go to that level of, have you been challenged on that particular issue? I do think there's no evidence of that is coming through in the data. So I'd be supportive of you taking that line and using this. I mean, clearly the one thing that we literally are still struggling with is people's confidence in other vaccines now, which are preventing much more serious illness and deaths in children, like the MMR vaccine. So, you know, we're seeing the most direct impact in our vaccine uptake rates for other vaccines at the moment than we are generally across the board. But yes, I think the patterns would suggest that you would have confidence in playing that back to your constituent. Thank you.
That'd be great. Thank you very much, Councillor Ritchie. I'm going to bring in Jane next, please.
Thank you, Chair. This is more a comment rather than a question, to be honest with you. I'm just looking at the childhood obesity, and whilst it is great that it's heading in the right direction, this last 6 months I had noticed that the trend wasn't right since it started, actually 2013-14. So it's a little bit scary to think that on average 23.3% of our year 6 children are obese, and in deprived areas it's 31, nearly a third of them are obese. So if you think of that kind of playing through the subsequent years into adulthood, that's kind of storing up a real significant health issue going forward from a population perspective. So I suppose it just reiterates why we absolutely do need to keep observing the kind of the obesity all age, really, because children kind of reflect the families that they live with in terms of behaviour.
Did you want to comment?
Yeah, thanks, Jane, and would completely agree. And as I say, we try and highlight where there's small positives, but overall, I think it's really important to keep sight on both that overall increase over time and the impact in the way that feeds through then into the adult levels and the consequent outcomes that we know occur as a result of that, and also those absolutely huge inequalities that exist within that between the most and the least deprived, with very, very stark differences, and we see those right the way through from reception age, those inequalities, and they obviously carry all the way through the life course, and you know they're associated also then with those other related outcomes that we see in here as well around physical activity and others, but also not very steep because of the high numbers. But if you also see the diabetes indicator as well, that's creeping up, and again it's increasing most in the most deprived, which is just worrying trends again. And we know about the association between type 2 diabetes and obviously an overweight and obesity, and you know a lot of evidence around that happening in younger ages increasingly. So agree, it's a concern.
Yeah, thank you very much for highlighting that, Jane. Okay, Councillor Hartbrook.
Hi, thanks for the data is really interesting. Can I just double check one thing, because I think it's the latest data, but on page 131 of the pack under the notes it does say data has been updated April 2023. I think it is newer than that, is it?
Sorry, do you mind just clarifying the question and to which particular?
Yeah, so on the tables, which is the one where it goes to landscape under population indicators. Under the notes at the bottom, it says indicators marked with an asterisk have been updated April 2023.
So I think that's just an indication, councillor, of the length of lead-in to these meetings. That although the meeting is being held now, because of the lead-in and the production of these reports, the numerous checks and balances and sign-off process that they go through, the actual sign-off, if you like, of the data at that stage before we then go into the full lead-in, actually probably was signed off in April, because there's quite a significant lead-in to hit the timescales for these meetings. So that will be. Oh, sorry, 24. Yeah, so it's April, but it will be 24. So
Yeah,
apologies.
yeah.
That will
I thought it was
I missed it. I missed the significance of your question. Entirely. My apologies. Yeah, it's not a year and 2 months lead into the meetings. It is only a couple of months.
Gotcha. I think there's some really interesting trends in here. I mean, I think there are some where the one that struck me isn't so much about what Leeds is doing. It's more some of our neighbouring cities across the M62 where we seem to be on trend with some of the national averages. Other cities seem to be behind, and I think some of the stories of what we're doing really well there would be really good. One quite quick question, and one stat that stuck out for me was the uptake of health checks, which is really high compared with what it's been before. And I'd just like a bit of a elevator pitch as to what we've done as a city there to get that really good result.
Could I just take the opportunity, Chair, sorry, just to add also the other bit that isn't included in there, which I think is equally important around that health check, is the uptake is fantastic, the recovery, but also we prioritise trying to reach those that are most at risk as well. And what we see is that the service is actually overperforming in terms of those it's reaching that are most at risk. So this isn't about just reaching almost the worried well, if you like, and those that won't most need it. We know that we're actually hitting those, which is, hopefully a really positive sign too. So thank you.
Thank you, everyone. Can't see anyone else indicating. No, okay, thank you very much. So that's very helpful. Thanks, Victoria and team. It's really useful to have this back. So we are now at the end of the meeting. Obviously, oh, sorry. I'm getting ahead of myself. Thank you. I'm being brought back in line. Okay, yeah. I'll start with Councillor Arif and then carry on.
Thank you, Chair. So I'll start off with the adult social care, if I may introduce the report, please. The report presents an update on adult social care activity levels and the latest position on measures included in the adult social care outcomes framework, which is ASCOF, as well as additional metrics which are relevant to the Better City Ambition, Better Lives strategy, or the Care Quality Commission, the CQC assurance framework. The content of this report includes the provisional ASCOF results for 2023 and 2024, informed by results of mandatory national data collection and surveys alongside the most recent comparative data from 2022 and 2023. As of March 2024, adult social care provided long-term support to 8,795 people. These figures continue to the trend of an increase in older people, and in particular an increase in the numbers of older people in permanent nursing residential placements, which rose by 8.6%. Adult social care continues to experience pressures on its services, and there remains high volumes of referrals into the system. In addition, people's needs are often more complex, and as a result, they need to be supported more now than they did previously. Whilst there has been a reduction in the number of vacancies, adult social care continues to face pressures in terms of workforce. It's worth pointing out that Leeds has a lower rate of social care staff in relation to its population when compared to similar authorities. The overall picture in relation to ASCOF measures compared to the last available result is positive, with 12 measures out of 22 having improved, whilst 9 have declined, with the results for the remaining measures not yet available. In terms of areas of strength, there's increased reablement activity and improved outcomes for people using the service, reflecting the Home First programme and operational changes. There's improving performance relating to safeguarding, with a reduction in appropriate referrals and improved outcomes for people going through the safeguarding process. There's improved performance on assessment timelines, with a reduction in the waiting list and average waiting times for Care Act assessments, with particular reduction of those with the longest waits. In terms of challenges, we have talked about this earlier. The take-up of direct payments is lower than similar authorities. An action plan is in place to include a refresh of information provided and identifying and targeting particular groups where direct payment may be appropriate. The ability of the service to carry out reviews has resulted in the percentage of long-term service users reviewed reducing. However, actions taken such as the development of a new reviewing team are displaying early signs of impact. Thank you, Chair.
Thank you, Caroline.
Thank you very much. Just a couple of things to perhaps draw out a little bit more, if that's okay. Councillor Arif has mentioned the workforce pressures. It's in the report. We know that the impact of not having a full workforce capacity and still carrying some vacancies or using agency staff does aggravate our position around timeliness of assessments and reviews. And our worry, even though we've got the checking and waiting well processes now in place, we are worried that, you know, people's health does deteriorate the longer they wait, and for want of an OT assessment and a piece of equipment that could prevent somebody falling and ending up in hospital. So we are really quite worried about the workforce challenges at a time when demand continues to increase. So I just wanted to bring that to your attention. Also, you will, of course, be aware that so much focus is around hospital discharge and pathways out of hospital, and we've got huge programs of work underway, including the Home First programme. But what that then means is that we're constantly robbing Peter to pay Paul, moving staff to address the hospital discharge pathway areas of work, and sometimes that's to the detriment of even our sort of approaches to working age adults. And there are massive pressures with working age adults as well. Often people with quite complex needs, challenging behaviours mean that there's quite extensive work to do with them to prevent them from ending up in long-term care, and that takes social work time and social work capacity. And we know that our NHS partners, particularly LYPFT around sort of mental health and learning disability, they're also struggling with workforce challenges, and therefore there is a bit of a push and pull between who picks up packages. So I certainly would welcome that spotlight and that work that you're proposing to do around the needs of people with working age adults. The point around direct payments, just to say that we have got a programme of work underway, but I'd like to pick up on Jonathan's point earlier around, is this exposing bigger issues around our ability to meet very much personalised care and support for our Leeds residents. And I just want to provide a bit of assurance that actually we do really well around personalisation. It doesn't get articulated by way of direct payments and the numbers of people taking up direct payments, but we can see that our wealth of third sector, community voluntary sector provision is ensuring that people are prevented from needing paid for care, because we're able to use that strengths-based approach and really help with identifying what's working well for people, what have they got in by way of community support, and that is keeping people healthy and living well and preventing their needs escalating. So there's a bit of bad news around all the pressures, but there's also some really good news around the work we do around very personalised care for individuals. Thank you.
Thank you very much for that. And just for clarity, so everyone else knows, we're currently in Appendix 2, which is page 151. I'm going to bring in Councillor Buck.
Yes, this is the first time I've been on this scrutiny board, and I'm just looking at page 118, paragraph 12. You say here the benchmark data shows Leeds ranked 6th of 8 English core cities for social workers per head of population and 7th for wellbeing workers. Can you just tell me, what are wellbeing workers and what is actually their role?
Of course. So some local authorities have social workers and then they have social work assistants who are not qualified as social workers, but who actually make up a large part of the social care workforce within a local authority. We don't call them social work assistants, we call them wellbeing workers, but they are unqualified social work staff who work with and support the work of our social workers. They might not take really heavy end and complex packages, big safeguarding investigations, but they do a whole lot of work around the sort of lower level, less complex areas of work.
Are there any other questions on the performance from the adults directorate? Yep, Jonathan.
Just a couple of things. Firstly, and it may be, Caroline, you've covered that in what you just said, but on page 153, objective 2, you highlight the fact that there's been an increase in the numbers of 18 to 64s in residential care, which you put down to some extent to learning disability, increase in learning disability. And I know what you just said, but it still feels a bit worrying that there's anybody really in residential care. So I just wonder what's happening around that. And possibly linked to that, in the data that's provided, unless I've missed it, which I might have done, and maybe it comes up in some other way, is there isn't much about the state of the social care market in terms of its range, where there are problems, quality issues, supply issues, etc. And I wonder if that's covered somewhere else in terms of what you provide to Scrutiny.
Thank you very much. So the first of the points around the numbers of people of working age adults entering into long-term care, you're right, we are really worried about that because obviously with that comes quite a significant pressure on our budgets. But to some extent, part of this will be explained by the fact that we're actually victims of our own success in that we have done really well in Leeds across the health and care system, getting people out of long stay hospital provision, the transforming care programme, as it were. And this is people who were not on the original list of transforming care, but have got quite high complex learning disability, autism, neurodiversity, mental health needs. We've moved them from out of area long stay hospital and we've brought them back home to Leeds, but at our expense. So the money hasn't followed those individuals. The money still remains in specialist commissioning in the NHS, but between ourselves and our ICB colleagues, we're picking up the costs of those packages. So yes, we are seeing an increase in the numbers, but they are people who wouldn't otherwise be able to be supported in supported living settings. Coupled with that, we are seeing older age of people with working age adults. So, they're categorised as under 65s working age adults, but their primary support need is their learning disability or their neurodiversity need, but they are also ageing. And we are finding that they live with family and carers or living supported living, and they can't remain living in those environments because of their physical deterioration. And so we're having to find that more are being placed in long-term care. We don't think that this is a situation that is unique to Leeds. Other local authority areas will be experiencing exactly the same. But yes, it is an alarming trend. I don't know if Shona wants to come in as well, because we do have a panel process, which is very, very rigorously looking at the best support package for individuals under working age adults. I don't know if you want to add some more, Shona.
Thank you, Caroline. For people with a learning disability, quite often what happens is they're living with family, as Caroline said, and then they get to a point where family can't support them any longer, typically in their 40s. So what we will do is in that emergency situation, people will be placed into a residential care placement just to make sure that they're safe. We then start to work with the individual and their family, and using the panel process, we will seek out appropriate alternative accommodation, and we would generally want to see people moving into supported living in that context. For working age adults with a mental health need, I did an audit a couple of weeks ago on people who were being admitted from hospital into residential care. And without fail, they had all been supported at a home or in a supported living context, had been readmitted to hospital, and on admission were so unwell that they couldn't return to their previous accommodation. And we had to seek residential or nursing care for them, primarily because of what Caroline has said, that there was an aging factor to their need. So all of those people that I audited, there was 10 of them, there really was no alternative but residential care for those individuals. We don't ever sit and say, well, that's it. If they're working age adults, we will try and seek a more independent option for them as we review their care.
And if I could come back to the second question that you asked around the state of the social care market. Historically, that hasn't been any of the sort of performance measures around that are not, you know, they aren't performance measures that we report on, and therefore they don't normally contribute to this report. However, we do take that sort of information to our adult safeguarding boards, the Leeds Safeguarding Adults Board. So that information there is a governance process in relation to that. It's just not routed through the Scrutiny Board.
Thanks.
Thank you very much. I guess we could do a work item on the level of staffing, that sort of thing, if we felt it was appropriate. So just to say that as well. Thank you. Okay, I'm going to bring in Councillor Ritchie next.
Thank you. Yeah, just reflecting on the report, and it might be that you're restricted by the sort of terms of reference of the actual report, the framework, but was this adult social care so connected and reliant, I'd say, to some degree on the third sector? Is that fair to say? And that's kind of not reflected even in the commentary, I would have said, and how the third sector are also now under their own pressures, so potentially putting some of that at risk. So I just wondered if there might have been an opportunity to reflect on that, but I understand if not, if it doesn't meet the direct report.
Very much. We categorise those sorts of services very much as prevention and early intervention, and they're not reported. We don't have performance indicators that are laid down for us to report on those. What we tend to do is we don't put those people who we signpost to our third sector, the neighbourhood networks, and whole range of other third sector organisations, including commissioned services like Live Well Leeds. Our social work staff route individuals to those organisations, but by doing that and that very personalised and preventative approach, those people then don't come onto our system, our client information system. So we don't capture the data around them. That doesn't mean that they don't get support and help. In fact, they get a lot of support and help, but they are not then counted in our data. But just to assure you, we absolutely do ensure that we make good use of the funding we provide to the third sector and all the services that they offer. It's just under the prevention badge. To some extent, you know, I think you make a really good point. It would be great for us to be able to find a way to report on those individuals that are benefiting from those preventative services, but there's no national sort of indicators data set requiring us to report on those.
Thank you very much for that, Councillor Ritchie. It's a very good question. And we all appreciate the third sector support that goes on in our community. So thank you. Okay. I can't see anyone else. Are you indicating? Yes, Jane?
Hopefully just a quick question. You've recognised direct payments needs improvement and you're setting up a project to do that. Have you got a theory why we're not doing so well in Leeds?
There are, in fact, multiple reasons, as you can imagine. One of the ones that we've been really tussling with is around our systems and processes and how difficult they are and complex they are for very, very busy social workers, because setting up a direct payment and getting a personal assistant or employed by individuals, it takes a lot of time and a lot of work. And when our social workers are so pressed around safeguarding matters, best interest assessments, and really focusing on assessing and reviewing activity, taking that time needed to set up a direct payment can be prohibitive. So we have been doing quite a lot of work in our embedding change team to try and simplify those processes. We've looked at how it works in other local authority areas and seeing whether we can adopt some of those. Again, to some extent, we're quite Puritan in our direct payments approach. Some local authorities will just sign people to home care agencies and say, here you go, have a direct payment, and these are the agencies that you can utilise. We would rather use direct payments in a much more meaningful way, which is to say, how can we equip you to employ somebody so that you're not just getting a bog standard home care package, but through that direct payment route. So to some extent, our figures are reported as low because we don't resort to just signposting people to agencies. But that's, again, there are numerous other issues as well, but we are tackling those.
Good, thank you very much. Okay, I'm going to move on to the active lifestyle. So back to Councillor Arif.
Thank you very much, Chair. So really positive results in reduction in Leeds physical inactive adults KPI, which is reported annually by Sport England. It highlights inactive rates have fallen for the period of November 2022 to November 2023 by 0.4% to 23.9%. The report highlights that this is lower than the national, regional and core city averages. Unfortunately, though, inequality still exists between the more affluent areas being more active than those in the most deprived areas. And as I said earlier, Chair, it'd be great if the scrutiny could perhaps look at that in terms of what we can do to encourage more activity in our poorest areas. So we'll continue our focus on place-based work within these communities to better understand the barriers to physical activity, including environmental factors and identify the support required to get people moving more. This is led by our physical activity ambition between Active Leeds and public health colleagues, together with partners from across the city. The Get Set Leeds local programme has expanded into Gipton and Hare Hills as part of the additional 2 years of funding from Sport England to enable Active Leeds to continue this excellent work in our priority localities where co-production and asset and place-based approaches are delivering some really, really good work on the ground. The team continues to work across the system, collaborating with partners and communities to improve people's lives for the better through physical activity and making Leeds a place where everyone moves more every day. An example of this is the Leeds Encouraging Activity in People's pilot exercise referral programme, which is starting to deliver some really tangible improvements to people's mental and physical health. Active Leeds will continue to prioritise their resources along with working with partners, stakeholders and community groups themselves in the place-based work to impact those in the greatest needs. Thank you, Chair. Pass over to Jane or Steve.
Thank you, Councillor. Yeah, just to highlight a couple of things in there, which obviously from our side of things, in terms of the new members wise, in terms of the data source for this kind of KPI, we kind of do pick it from the national kind of survey that Sport England do. There are some limits to that data in terms of the quantity of data sources that they kind of do use as part of all that. So it is a survey that goes out for the Leeds people, but it is kind of limited on the numbers of people that it reaches and the likes, which then makes it quite hard to break that down further in terms of looking at some of the demographic data behind some of that as well, which then kind of doesn't lead us to allow us to kind of focus on particularly those areas. So there are some limits to that data, but it's the most robust kind of data that we kind of find to be able to draw some comparisons with the likes of the national, regional and kind of core city side of things, which we all the indicators kind of point towards these being very positive on that front. But obviously, as Councillor Arif kind of highlighted, the health and equality side of things is still something that we need to kind of focus on, and that's where we do do plan our resources, although activity rates have increased in those areas as well, they haven't increased as fast as the more affluent areas, which is our challenge as we move forward. Performance wise across the piece, things are very positive from a physical activity perspective. That's in terms of the usage across leisure centres and the likes that we kind of monitor quite extensively. But again, from our side of things, it's how we kind of reach the people that need this support that we kind of really need to drive forward as we work over the next course of the year. Thank you.
Super, thank you very much. Open up to questions from members. Just a comment from me at the start. So I think the Get Set local stuff has been really, really positive, certainly where I've seen it in my ward. And I also think, again, mentioned earlier, the idea of hyper-local facilities is really important to give opportunities to have activity. I can't see anyone indicating for questions. No, but really positive. Thank you very much for that. Still more to do, and I think we'll probably talk about this again when we do our piece of work around healthy weight. Good. Okay. I think we are at the end of the meeting now. This time. So thank you very much, everyone, for coming. Appreciate your time. Welcome to the new members. Hope you enjoy this board this year. Especially welcome to our new co-chairs who are co-opted members. So thanks for coming, and see you all next time. Thank you.